Hello and welcome to the 15th McKnight's online forum. You've tuned into Overcoming Staffing Challenges and Patient Isolation with Virtual Care. This morning, we'll be examining how innovative technology approaches can engage patients and enhance care offerings, even amid staffing shortages. I'm McKnight's Senior Editor, Kim Marcellus, and I'll be moderating today's event. I'll introduce our speakers in just a moment, but first, we have some housekeeping to address. If you have any audio problems during today's presentation, please first check the volume control on your device. This is the most common issue. Sound should be coming from your computer speakers. We will have time for a Q&A session near the end of today's presentation. So if you have any questions, please feel free to submit them starting now in the Q&A box on the left side of your screen. Also, today's slides are available for download or printing. Check the handouts box, which is also on the left side of your screen. Now, regarding continuing education. This educational offering has been reviewed by the National Continuing Education Review Service of the National Association of Long-Term Care Administrator Boards. It has been approved for 1 clock hour. However, you need to stay tuned to the entire event during its original broadcast to receive a certificate. You can track CE requirements through the course completion tracker, which is accessed to the last icon in the area below the open webinar panel. Once you have achieved 50 viewing minutes, a View Certificate button will display, and the required viewing duration will have a green checkbox. You can then view or save your certificate. A copy will also be emailed to you afterward. Finally, this session will be archived and available on demand shortly after this live broadcast. You can access it again, or others can experience it for the first time by simply going to the registration page to enter the studio. The URL is www.mcknights.com/03-2222onlineforum.com. We'd also like to note that this program is made possible by support from Birdsong and AMC Health. Now, let's meet today's presenters. Aisha Azher is the Marketing and Delivery Enablement Executive at Birdsong Life. She's working to make bedside engagement technology the standard of care in the senior living industry. John Nash is Vice President of Sales at AMC Health. He has more than 20 years experience in healthcare, much of it driving technology innovation to improve patient experience and providers' financial results. Over the past 5 years, John has focused on all aspects of care coordination, including health coaching, care and referral management, remote patient monitoring, and virtual care. And finally, last but not least, we have Mary Arthur. She serves as an options counselor with Dementia Focus for Bay Aging, a local aging services provider. Mary is a certified dementia practitioner who also serves as a memory care consultant for long-term care facilities and home care agencies. And with that, I'm going to turn the microphone over to you, Mary.
Thank you so much, Kim. I appreciate that. And thank you, everybody, for joining us this morning as we discuss the overcoming staffing challenges and then, how can we combat loneliness by implementing engagement technology. So I thank you guys for being with us this morning, and I look forward to talking with you more. So we're going to jump right into it. I'm sure you guys are aware of the data that's out there. Obviously, this isn't going to shock many of you, but the data shows that everyone is experiencing shortages, particularly around nursing and home health aides, and reporting that they're unable to admit patients. And according to William Dambai, president of the National Association for Home Care and Hospice, on average, agencies are rejecting as many as 40% of new referrals. I know in our small rural area where we have an abundance of retirees, all of the home agencies have a wait list that I've heard of over 100 people waiting for services, and they're turning away most referrals. In mid-January, the Pennsylvania Home Care Association surveyed its members, which are Medicare certified home health agencies, which provide assistance from aides, and skilled nursing and therapy services, and state licensed home care agencies, which provide non-medical services such as bathing, toileting, cooking, and housekeeping, often to people with disabilities covered by Medicaid. According to Harry Henning, the association's chief executive officer, they found that 93% of Medicare certified home health and hospice agencies and 98% of licensed agencies said they had refused referrals during the past year. I work in caregiver support, and the response is overwhelming at times. There is a large amount of family members, neighbors, or even distant relatives that have become caregivers. The CDC reports that 1 out of 5 Americans consider themselves caregivers. What all of this means on a practical level is that seniors, their families, and clinicians are all being impacted. For seniors, Ken Albert, president of Azher Home Health Care and Hospice in Maine and chair of the National Home Care Association's board, said that they are seeing increasing demand on adult protective services as a result of people with dementia not being able to get services. He said the stress on families trying to navigate care for their loved ones is just incredible. Abraham Brody, associate professor of nursing and medicine at New York University, went on to explain these complex interconnections. When frail older patients can't get adequate care at home, they can deteriorate and end up in the hospital. The hospital may have to keep older patients for several extra days if home care can't be arranged upon discharge, putting people at risk of deteriorating physically or getting infections and making new admissions more difficult. When paid home care or help from family or friends isn't available, vulnerable older patients may have no other choice but to go into a nursing home, even sometimes when they don't want to, but that's all that's available. But now many nursing homes don't have enough staffers and can't take new patients. So people are simply going without care. Patients with terminal illnesses seeking hospice care are being caught up in these difficulties as well. Abraham Brody is running a research study with 25 hospices, and he said that every single one is having staffing challenges. Without enough nurses and aides to meet the demand for care, hospices are not admitting some patients or providing fewer visits. What this means for families is that people who have long-term care needs and a high chronic disease burden, agencies just aren't taking those referrals, and instead families are filling gaps in home care as best as they can. Before the pandemic, hospice agencies could usually guarantee a certain number of hours of help after evaluating a patient. Now they are really not able to guarantee anything on discharge, which means that now they really have to rely on the family for almost all hands-on care. This results in overburdened family caregivers who are stressed out to the max. And what all of this means for agencies is that they aren't able to serve as many seniors as they would like to be able to, and their current staff is overburdened. And we're seeing a lot of those staff leave the healthcare field. From a financial perspective, agencies are also losing out on potential revenue that they could be getting if they can expand their services and serve more patients. So now we're going to talk about leveraging technology to engage the patient. Now, how can we overcome these challenges through technology? We can go about it in a number of ways. First of all, for seniors who are already struggling with a lack of engagement or mental stimulation because of the overburdened caregivers, we can now provide them with enriching opportunities for mental stimulation. If they are given easy access to content that they are interested in and they're passionate about, that will help improve their psychological well-being. Aisha will cover this a bit more shortly. You can also provide them with easy opportunities to video conference with their loved ones. Once they are able to independently connect with their friends and families, those feelings of social isolation will reduce, and their family will be more in the know as what might be going on with their loved ones. Caregivers in the home can set up games, music, videos to stimulate their loved ones while they're tending to daily chores, work, or just a chance to rest. Lastly, to save time on the clinician's end, we can set up patients to be monitored remotely. This means that clinicians will be able to monitor biometrics without having to travel to the senior. by saving on travel time and the gas money, they will be able to serve more patients, which means more and more seniors will get access to adequate care. And that's what we're all here for, right? So Aisha, I know you're going to talk about this even further. So jump right in.
Thank you, Mary. Going off of what Mary mentioned, Birdsong partnered with Eastern Virginia Medical School to study what happens when seniors are given an easy-to-use tablet that's designed for them and customized according to their interests. And what we found was incredible efficacy. As you can see on the right-hand side, these are just the overall results in decrease in caregiver stress and decrease in depression. There are many antipsychotic and anti-anxiety medications on the market that lack this type of efficacy and they have side effects. What we did was through a non-pharmacological method, we were able to decrease depression, blood pressure, as well as increase cognition. All of these findings were statistically significant. And obviously, this was really eye-opening for us to see the results of this study. And really what we did was that we took all of this research and we put it into practice with the Birdsong Tablet, which contains over 8,000 diverse, engaging experiences and has an easy to navigate user interface that is specifically designed for seniors. Mary, could you share a little bit more about how you used the tablet to engage your residents?
Yeah, certainly. So there's so many different opportunities on the tablet. As Aisha mentioned, the Birdsong Tablet has over 8,000 different experiences that can meet the needs of all seniors. Even those seniors that you think may not enjoy working with a tablet, maybe they left the workforce because of computers. I would sometimes just put on trivia games, and those residents that often say they're not going to play with it, they're not going to touch it. They were one of the first ones to answer those trivia questions, and before long, they were touching the button on the screen. And so when you're really looking at all the capabilities, we're going to get into video calls more in a minute, but this is a really good way just to keep loved ones connected. I know throughout COVID, we couldn't have visitors in our nursing home, and you could just see, the lack of mental stimulation. They weren't eating because they weren't stimulated. And so once we started engaging with video calls from the family, it just really inspired our residents to keep going, to know that they could see their family members. It was really, really engaging. Photo sharing is so important. If you have someone living on the East Coast, someone from the West Coast, or anyone around the world can send your loved one photos. And so they're keeping up with the family. They're seeing new babies or, weddings or graduations. And you can even do video calls and Skype with them through that. But photo sharing is really important. And this is another thing, if you really elaborate and think bigger on it, this is a way where you can get your staff involved with that resident. They can get to know them a little better if they know their family. We had residents' families sending us photos of the person when they were young and when they got married and all of the different accomplishments. And so it was a really good chance for our staff to connect with the residents on a different level than just providing the care. And then games are really, really fun. Everybody loves the games. There was one game that only everybody wanted to play. Even with dementia, they could do one of the games where they swipe the fruit. And you could see the smiles on their faces that they accomplished something, that they, didn't forget this, and they didn't mess up. They won, and they had an achievement through the games. And so some of the games are, for memory. And so those early stage memory patients that you may see, this is something to really help them stay engaged, to stimulate the brain. Spirituality is so important. And then all of the different faith religions and different resources are on the tablet. I know that for many, faith and spirituality helps them just calm down, and it provides that comfort. And so putting on old church hymns, their favorite scriptures, or they can connect with the church that they haven't been to in years, or a church home that they that they grew up at. Now there's all types of virtual services. And so this is also just really helpful, especially for those that maybe the staff, they don't know how to connect with someone of a different religion. Well, here are all the tools you need to connect them. You can just have the staff, aware of that person's beliefs, and then have some interventions in place for spirituality. We know that music keeps it going, but really diving deep in the morning, putting on big band or upbeat music is really setting the tone for the day and for staff. I used to just put, different types of 70s songs on our tablets at the nurses station. And before long, there was staff dancing around. So it had a direct impact on our residents because staff were engaged, happy. And then in the evenings, when you think about those residents with sundowning and dementia, you put on relaxing music or even relaxing nature sounds and nature videos. People really, really connect well with that. And then reminiscing is always good. You can look at those classic black and white TV shows or movies, or you can just look up on YouTube, classic toys, classic devices. Sometimes I was in a farming area and I would put up classic tractors, and all the men would flock around the tablet. And then travel was really important for our facility. Most residents were trapped inside of their room if they were on quarantine, but our residents, I said, were traveling around the world using the tablets. And so they can travel to countries, watch, food from different countries being prepared. And this is another really good way to entice appetite by showing them food videos associated with the travel. And then lifelong learning. We all know that sometimes it's hard to engage male residents. They don't want to do crafts or art all the time. And so lifelong learning, they can watch special TED Talks, university and lectures. And so it's really engaging them on a different level. I know that John has some really good examples of, how videos calls can really impact the quality of life for seniors. So John, you want to jump in and tell us about that?
We can kind of transition some of this discussion beyond the social isolation that we're talking about, and really think about how we can leverage this technology to benefit the physical health of these residents and patients as well. And when you think about that connection that you discussed in when you're talking about leveraging video calls to connect with loved ones, I think that concept can be expanded, and it's a big part. Video calling, virtual visits, is a big part of the telehealth, virtual health topics that we'll be covering here as we move forward here, because that connection, that personal connection, can also be with a caregiver. And when we're leveraging this technology to put that friendly face that can be reached remotely when that patient has a question about something related to their health, or if they need something, they might need they have a concern they want to talk about. Seeing that person on the other side of that really reduces that isolation, not always just with family members and friends, but also with those clinicians as well. The other thing that kind of jogged in my memory here, or jogged my thinking while you were talking, the lifelong learning piece that you were just talking about is such a foundational component of virtual care, because what we're doing, what we'll be speaking about here in the coming slides, is engaging that patient in their own health. The more we can provide them with education, enhance their health literacy to understand what's happening in there and how their chronic conditions, can change based on their day-to-day decisions about diet or about the activity levels, et cetera. That's also fueled by that desire for lifelong learning, and it's learning that affects them. Mm-hmm. These are two key pieces that can be where we're leveraging that technology to really connect and to really enable that 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 engagement where patients really start to take control of their physical health as well as their social well-being that you've been talking about. So I appreciate your mentioning those things.
Thank you.
Excellent. So let me jump right in there, and I appreciate the background that Mary and Aisha have. They've done a phenomenal job of kind of explaining how technology can be leveraged to enhance the lives of seniors. And as I started talking about there on the last slide, I want to transition a little bit to talk about how about leveraging this technology to improve their physical health, and to do so in a way that actually makes it easier for those that are tasked with providing care for them. As we're talking about these staffing challenges, everyone in one way or another is concerned about doing more with less. And before I get into the numbers here on the slide, these statistics, what I'll do is let me do some high level definitions so I don't throw around any concepts or terms that people aren't entirely familiar with. Let's start with this basic concept of utilizing technology to connect individuals with their healthcare providers, and to do so remotely or virtually. That's actually the simplest definition of telehealth. Telehealth is one of those buzzwords in the healthcare industry. Everyone's talking about it, asking about it, especially amid the experience we've all had with COVID over the past few years. And telehealth is simply connecting those healthcare providers with their patients, and vice versa. And there's multiple ways of doing that. Many people think about telehealth and they think of these virtual visits, these video visits that we were just talking about on the prior slide. And it's really too narrow of a definition because if you're really thinking about telehealth as connecting people with their providers, you realize those virtual visits that have certainly exploded in the past few years during this pandemic. Those virtual visits are just one tool on that telehealth tool belt, so to speak. Other tools that are on that belt include things like chat-based interactions, chat between a caregiver and a patient as they maybe text back and forth about something that they're facing or a challenge that they're facing. Remote patient monitoring, or as you see on the screen here, RPM is the acronym we'll be using. We'll be chatting about that here for the next few minutes. And as we build on that concept of telehealth and virtual care really just being that connection between the patient and their provider, RPM is simply another modality for doing that. RPM involves the collection and evaluation of individual health data and getting that data from a patient to their provider in a manner that, and here's a key part. Here's the key part when we talk about doing more with less. A manner that analyzes that collected data and alerts the provider when a particular patient needs assistance. So as you think about the workload of our nurses and our clinicians, when we're leveraging a well-built RPM program, those providers aren't expected to be continually checking in with those RPM patients because they're receiving alerts when the patients need something, when that data being collected demonstrates what might be a risk factor, something that needs to be followed up on, something that needs to be where an interaction with that clinician is required. So now that we've kind of established this foundation of a basic understanding of telehealth and RPM, I think you all are in a better position to wrap your brain around why these approaches are seen as very key elements in the healthcare delivery system at the current time. And now we can start to look at the statistics on the screen here. The picture really isn't all that pretty when we consider that over half the adult population is living with one or more chronic condition. conditions like heart failure, COPD, hypertension, diabetes, etc. And among seniors, estimates say that over 70% of people are having at least one of those conditions. Many of them have multiple conditions, comorbidities, as they say. Beyond, I actually stay right there with. There we go. Thank you. Just a couple more points here. So beyond just looking at the staggering costs, as you saw there, the $3.5 trillion spent on folks with chronic and mental health conditions. We touched on a couple of the challenges here on the right-hand side of the screen there. Challenges with medication adherence. Challenges with, their things that get out of their control a little bit, and all of a sudden they're back they're in the emergency room, or they require hospitalization. Many providers try to create chronic disease programs, but those fail because they simply don't engage the patient sufficiently. So you see the problem. It's hard to keep track of these patients and their ongoing needs. So next slide, please. So this is where RPM comes in, and as we think about the difference in the care models, it's probably worthwhile to just kind of touch on that briefly as we go into this. Rather than the traditional care model, regular checkups with a provider, which could require transportation depending on the patient situation, so that providers checking blood pressure, blood oxygen, glucose, etc., and maybe adjust those medications accordingly until they hopefully see you again in whether it's a few days, several weeks, or even a few months. Right? That's kind of the traditional model. Contrast that with an RPM model. A patient receives a kit that includes 2 or 3 devices. Maybe it's a blood pressure cuff and a pulse oximeter, weight scale, or a thermometer, and they're trained on how to take their readings on these devices on a regular basis. Those readings, along with regular responses to simple interactive surveys that might ask questions about potential symptoms, which might determine if that patient's retaining water. A heart failure patient could be retaining fluids. All of that information is collected and analyzed in a way that identifies which patients need the assistance of a clinician. We'll dig deeper into the important elements of a successful program here in a few slides, but I think giving that 30-second overview, you can kind of envision what's involved and how it becomes the answer here, as we're saying on the slide here. You're essentially delivering with an RPM program, or I should say a well-designed RPM program, two characteristics that don't normally exist in the traditional approach that we were talking about earlier. And those are consistency and timeliness. With consistent measurement of those key clinical metrics, such as those that get taken during those checkups that we were talking about, patterns or trends are identified and managed before they become a serious issue, which could lead to hospitalization or a trip to the emergency room. And when a concern is identified, the follow-up takes place in a timely manner, often without a hospital or ED visit being needed. I think that one way to look at this is think about a home. If you have the ability to identify faulty wiring in the walls before a house fire happens, you want to do everything that you can to do that. And that's essentially what we're doing with RPM, identifying these things that a patient might not even notice. A patient might not notice that their weight is steadily increasing, or their blood pressure is out of whack, or that they have that they're actually identifying symptoms that could mean that their heart failure is worsening. So by doing that, by collecting that information, and as you see here, we see a significant reduction in ER visits being avoided, reduction in hospitalizations and readmissions, which obviously has a major impact on healthcare costs for both inpatient and outpatient. we also see considerable increase in satisfaction for the patients, and that's what we'll talk about here on the next slide. It's easy to understand how logical RPM is, right? It makes perfect sense that collecting this information is valuable in providing care, but we all know that perception's reality. So we've spent some time during the public health emergency and the COVID pandemic, and collected feedback from lots of patients that demonstrate the value of this service to patients. And this is what's the question that's asked is, we ask them to identify the top benefit that they perceive with their RPM program. And it's very interesting to see that we see that 43% of patients cite convenience as the top benefit, followed closely by efficiency, control of their personal health. That and as we talk about control over their personal health, peace of mind, both of these, it's regaining control, right? We're empowering these patients as Aisha and as Mary talked about, in utilizing the technology around socialization and avoiding isolation. We're giving that patient control. These devices are helping them establish themselves as someone that can be a major not just a participant, but an active driver of their health. And that's one of the true driving forces behind what we do every day is identifying those patients and empowering them to improve their health through their own actions. Next slide, please. So this is where we'll get into a little bit of detail on the key elements of successful RPM programs. And I think there is often a bit of a misconception that it's as simple as, going to Best Buy, grabbing a device and connecting that device via Bluetooth or something, and then you're good to go. It's far more extensive than that. And experience has shown that you really have to look at each of these 5 areas that I've laid out here on the screen, and really think about them very, very specifically, and make sure that you're considering each element here as you build your program. It starts with enrollment, and that is not a simple piece, because you're identifying the patients to be included in your program. Maybe that's based on certain chronic conditions. Maybe you've got a group of patients that are heart failure patients that, or maybe you have a group of COPD patients or patients with long COVID. These are identifying which patients can benefit from a program like this is a big piece. And there are many organizations that assist you in doing this, various ways to look at your data to understand which patients would be the best fit. The next piece of that, the next piece of the outreach element here, is engaging those patients in a formal onboarding process. This is where the patients, you're not just communicating to them that they're in this program. You're actually working with them to make them comfortable with the devices that they've received. And you're also, here's the key piece, is leveraging people that are trained in motivational interviewing techniques. This is where understanding what drives that patient in their, what makes them want to be. Maybe it's they want to be healthy enough to see the birth of a grandchild, or to see the wedding of a grandchild. Who knows, right? But understanding those things is an important part of engaging those patients in the onboarding process and that gives that to understand what the motivation is for each individual patient. The motivation is rarely clinical, right? The motivation is something in their life that says, hey, I really want to take control of my health. That you're providing tools to enable them to do that. The next piece is logistics, and this is often a piece that kind of gets forgotten, but it can become somewhat onerous and cumbersome to keep track when if you're sending this out to 50, 100, 500 patients, and you're trying to keep track of who has what devices. Are these devices, set up properly, and are they received by the patient, and are the shipments being tracked? Are we making sure that the patient's ready to use them with the proper setup guide and instructions? You don't want to force your organization to have to run a FedEx shipping department. So it makes sense to ask these questions at the beginning. Who's handling the logistics? Do we have a strategy for that? And make sure that approach is very well defined. The third piece, engagement, and we've talked about this. Flexibility is a key, but I think what we're talking about here, the beauty of the program is you want to make sure that you can leverage that technology that you're providing. So we're talking about the Birdsong tablets as being something that is a technology piece that has been shown to assist with that isolation. Leveraging that same technology is a real benefit for your RPM offering to leverage that same tablet. We talked about two-way messaging and video. I'll talk here again. I did something I talked about at the beginning is the educational tools and resources. This is something that is extremely valuable because oftentimes patients don't have a great understanding of their chronic conditions. They may have been told years ago they have COPD or they're diabetic, and there's a decent chance that they don't know what that really means and how their day-to-day decisions can impact the status of that condition or how they're able to deal with that condition. Providing them with educational resources around that condition and around, what are signs of exacerbation of my COPD? What should I be looking for? What are things to be looking out for? That's extremely valuable. So as part of your RPM program, you want to be able to provide that information in a consumable way, whether it's short video vignettes or it's reading material. You need to meet that patient where they are so that they understand that you bring them that understanding that they're playing a pivotal role in all this. The fourth pillar here is the actual clinical monitoring, and I think the key here too, especially since we're talking about staffing, is making sure that you're leveraging a system that's truly identifying the patients that need assistance. It's not simply a matter of show me which patients who are showing high blood pressure. It might be blood pressure in addition to how recently they were last in the hospital, in addition to how they're answering some information on these interactive surveys that we had talked about. So connecting all of those dots, because there can be in a program that's not set up properly, there can be an issue with alert fatigue, where the clinicians are simply receiving so many alerts, and they're not always alerts that tell them about a patient that needs assistance. It could just be a value that's outside the norm, and that's doesn't always reach the level of requiring an alert. So you consider the clinical services involved, whether that's just how are we going to respond when an alert comes through, or do we need clinical clinical resources to assist in the entire process. That's kind of that what we see there is the TCM, or the telecare management clinical support. Maybe you need staffing assistance to provide specific elements of this, and that's, again, questions to ask when you're starting these programs out. And finally, I kind of talked about this at the beginning of this slide when we talked about understanding motivation, right? The goal here is to help patients, to empower patients towards self-management and what we call graduation, graduation from the program. This heart failure program, this COPD program, et cetera, where they've taken control of that condition and it's now part of their daily lives. We've had plenty of situations where patients have graduated from the program, but they refuse to give up that blood pressure cuff and the interaction of that data being sent to someone watching it, because it's a bit of a security blanket. But the goal here is to be able to help that patient to accomplish that level of control, and that's what always has to be kind of that overall target, and kind of the organizing principle of these programs is to engage the patients to that level to where you can take them to where that they can complete that program. I just talked for a long time, so let me take a breath here. I think we've got Aisha, you're gonna take it back here.
Absolutely. So hopefully what we shared with you today brings value to you. And thank you, John and Mary, for a great presentation. We're really glad that you joined us today to learn more about how just virtual care and engagement opportunities served through technology can help your seniors, your family caregivers, and clinicians. If you are open to implementing something like this, or if you have any questions, please don't hesitate to reach out to us. We have a team of consultants who would be more than happy to provide guidance or just provide more information. So you can email us at info@birdsonglife.com, and we'll get back to you right away. So with that said, we'll open it up for questions. I know I've seen a bunch of questions come in already, and we'll just jump right into questions for the sake of time.
Yeah. Thanks, Aisha. Appreciate that intro back to the Q&A, and we do want to get to those. I think it's really interesting because certainly we saw telehealth explode during the pandemic, and there's kind of this moment now where we have to decide, or providers, I shouldn't say we, but providers have to decide what technology looks like going forward for them, and what's the best use, both for their staff and I guess on an investment level. So I'm going to go to this question first, and we're talking about investing in this. I've heard there is some government reimbursement for remote patient monitoring. Can you please go into more detail, and how do I navigate that and potentially help offset the cost of investing in the technology? And John, maybe that's for you.
Absolutely, and it's a great question, and we could probably do an entirely a focused educational session on that. But you're absolutely correct. CMS does have reimbursement for in the current year for remote patient monitoring services, and generally it varies by state, but generally the reimbursement is in the range of $120 to $150 per patient per month for providing these services. Now, there are requirements that say you have to take 16 days worth of readings. So the patient has to connect their blood pressure device or their pulse oximeter, whatever, depending on their chronic condition, right? But there has to be 16 days of data, and the caregiver or the clinician has to spend a minimum of 20 minutes reviewing that data, or working with the patient around that solution. There's also a there's also a reimbursement specifically for the setup of the devices. So those are all just different elements. It's like you've got the setup reimbursement, then you have the once you reach the 16 readings over that time, you can get reimbursed for that as well. But it's a much more involved process, but that's something that we've certainly worked with in the past. So I can get into greater detail if folks are looking for more info.
And I guess I would say, not speaking for you, maybe you can elaborate on this, but I think you maybe also have to look at it as what's the ROI, the intangible that takes some time to get to.
Absolutely. And healthcare sits in the, with a foot on the dock of fee for service, while we're all trying to get into the boat of value-based care, right? So when you think about those benefits that we talked about of RPM being extensive and reducing the cost of hospitalization and reducing readmissions and trips to the emergency room, those are cost savings, considerable cost savings that would far that would far exceed that $120 a month that I was talking about that you can get reimbursed for on an individual patient level. But CMS has done a decent job, I'll say, of enabling that reimbursement. I see that as a bridge to get us all to where, we're thinking about things in terms of, driving health rather than, being focused on fee for service reimbursements.
And forgive my ignorance, but just to clarify, is the reimbursement amount that you're talking about, is that specifically for home health, or is that available to SNFs as well?
That
post-discharge?
It is. I would have to look at that and get back to you to get the specifics on that. I think that is generally for a CMS certified provider to. I would have to check.
Okay.
Specifically.
I didn't mean to throw a hard question at you. I just really didn't know. So.
You did. Good job. Challenging me is a good thing, and I apologize for not knowing that off the top of my head.
All right, let's jump into a question about implementing a platform like this. So I think a question folks would have to say, where do I start? Is it for every patient that I have? How can I predict who would benefit, and how do I roll that out? Aisha, might that be something you want to answer?
Absolutely. So that's a great question. When it comes to engagement technology, I'll answer the part about engagement technology, and John can chime in on the remote patient monitoring aspects.
Sure.
But when it comes to engagement technology, early on, before we implemented a program like this, or before we started doing our research studies, we weren't sure whether or not our seniors would adapt to it, whether or not they would start using it. And there were some seniors who were like 104 years old, had advanced dementia, and we were pretty doubtful. And but we said, for the sake of the study and actually studying how seniors engage with technology, we need to control our biases. So we made it available for everybody. And as a result, what we saw shocked us. We saw seniors who were nonverbal, who had dementia. Actually, they were on their tablets playing solitaire and really just engaged and mentally stimulated, and we saw them become happier. You could see a visible change in them, that once they had something that was, that catered to their interests and their passions, we saw them light up. And that was something we wouldn't have come across or discovered naturally. So what I would urge anybody who's listening is sometimes seniors will surprise you. So everybody deserves a chance. Give them a chance, and show them technology and show them content that's meaningful to them. and wait for their response. And at first you might get some people who might reject it, or who might, be a little apprehensive. But if you're patient with them, give them a couple of opportunities, ask them maybe at another time when they're in a better mood, you might get a different response. So my answer to that is, it is available for everybody, and we've seen seniors of all ages, of all cognitive levels, just really respond well to it. And Mary, I know you've had quite a bit of experience implementing engagement technology with seniors of all backgrounds and cognitive
Mhm.
levels. Um, how has your experience been, and when it comes to implementing it, any advice you'd like to share?
Yeah, so I always say that it really is the staff buy-in first. And so, I didn't rush it. I started showing the staff the benefits of it. I started playing, the music, or laughing baby videos, and the staff were laughing or dancing. And so it was a very positive response. We implemented it in our facility, training everyone, including housekeepers. And housekeepers were the first ones with a huge buy in, engaging residents and learning things. And there's a lot of different things that Birdsong will help you with. And, I know other companies as well, when you're implementing them, because, you may want to go slow. There may be incentives like, we challenged our staff. If you can find out 5 new things about a resident, write it on this list and we'll enter you into a chance to win a gas card. And so there was a lot of, small incentives, but then once they saw the benefit and that they could engage their resident and then keep going to do the rest of their work for the day, it was just an automatic buy-in. But I think just going slow, training people, staying positive about it. There were days where, I would just let a resident play a game on it, and that person wasn't trying to get up constantly because they have dementia and can't remember they broke a hip, right? And so instead of constantly saying, like, you have to sit down because you broke a hip, da 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 da, over and over, we just played some of his favorite baseball videos. And that kept him sitting. And so then everybody's like, that was the buy-in. And so just go slow and it'll go well, because you can see the benefits automatically.
John, did you want to add anything on the
Then,
RPM
John,
side?
would you want to
Yeah,
chime in from?
yeah, sure. I think on the when you're talking about RPM programs, there is a little bit there's a clinical element to it. So it's really, you know, you want to focus on those individuals that can benefit the most from it, right? So you'll have some individuals that are lucky enough, or don't that do not have those chronic conditions. But I think generally speaking, you'll want to focus on the primary chronic conditions, the patients that have the heart failure with COPD. Maybe they have long COVID or hypertension, et cetera, and build the programs around those populations specifically as a layer on top of the, because I think the engagement technology, as Mary and Aisha are talking about, has value for everyone. You'll have that subset of patients that also have these chronic conditions, and you'll want to focus the RPM piece on those individuals.
So let me jump in there with a different but related question then. So again, thinking that we might have some skilled nursing providers here with us today, can you talk about what you've seen with using RPM during the transition or the handoff to home? Are you seeing more collaboration between SNF and home care agencies, or even home family caregivers, to capture data and spot concerns early and get at that readmission concern?
Absolutely, because what it comes down to really, this is care coordination at its best, right? So understanding when patients have are in that 30 to 60 day period and a post discharge, you want to make sure that you're able to understand if they're exhibiting signs of their condition worsening, right? And oftentimes, as I mentioned, that can be done in a way that avoids a return trip to the hospital. But it all really comes from understanding not just the clinical elements, but those non-clinical symptoms, those surveys, et cetera. And we've got lots of great examples of different providers, whether that be hospital care managers working with home care providers or working with skilled nursing facilities to understand these things, because everyone has the goal in mind of avoiding that readmission. The readmission penalties are too great for everyone, so that coordination really supports that kind of really supports that the ability to avoid that.
Yeah, that link over is so important. All right, I think we have time for one last question, and I'm going to kind of go back to a very basic one. And Aisha, maybe you want to jump in here. But essentially, if I'm looking at a variety of platforms, I know I want to do something. What are the aspects of either the tablet or the platform that you think can make them more intuitive or welcoming for older patients? And particularly maybe if you have an older patient who has a family caregiver that also is hesitant to use technology. What are those kind of key factors that folks should look for when they're considering?
That's a great question. So first one, before we even get to content and whether or not it's engaging enough, it has to come down to ease of use and accessibility. The platform itself has to be easy and intuitive for the senior to easily navigate through. And what that comes down to is there are so many things where people who've had experience with technology that might be intuitive to them, but they might not be intuitive to people who are new to technology. So one thing that I come across quite a bit is swiping. We're used to swiping on an iPad or an iPhone. We can swipe left and right, and we've memorized what the swipe means and which way to swipe for what. And if you've seen people who aren't used to technology, and especially older adults who may have shaky hands or shaky fingers, and you ask them to swipe, they may accidentally swipe and they don't intend to swipe. Or they might forget, which way do I swipe to go to the next screen, or left or right. And what we've done after we did our research studies, what we realized is we need to have buttons for everything. I have a back button, a next button, an up and down button, and people need to navigate through just by tapping and touching. So that's something that we hadn't realized before, but after our studies, we saw that swiping was a major hurdle. And something that's a little obvious is people have visual impairment as they get older. They tend to have more visual impairment. So, big icons, big font sizes, huge color contrasts. You don't want to have like a light, gray font on a white background. It's harder for people with aging eyes to be able to see. So navigation needs to be easy. And then when it comes to content, that needs to be engaging for older adults. You can't put engaging and dignified. You can't put content for that, might be interesting for a 17-year-old. That same content might not be as interesting to somebody of a different demographic. So content has to be diverse and meet their needs and interests. And then from an organizational standpoint, it needs to be cloud-based. So when it comes to implementing technology, I've seen this when we were looking to partner with a remote patient monitoring company. A lot of the companies we came across, their data wasn't hosted in the cloud. And what that would mean is when it came to getting this, blood pressure monitoring or weight scale, data and having it at a cloud server, the process involved in that was very cumbersome. It would involve like nurses going to the patient's home to retrieve data, or the patient having to download data and emailing it somewhere. That was hard. So when we came across AMC Health and saw how intuitive it was to retrieve data and host it in the cloud and have all of that to be automated, that we saw that was really nice and made it easier for the patients to continue on with the program and share their data.
All right. Well, thanks for recapping those elements, and folks can definitely investigate that. So with that, we have to end today's session, and we want to thank our viewers, and we hope you all enjoyed this. As a reminder, our next topic for the forum is workforce hurdles and solutions across the long-term care continuum, and that kicks off at 12 p.m. Eastern. After today, both sessions will be available on demand at mcknights.com/03-2222onlineforum.com. We'd also like to give our special thanks to Aisha, John, and Mary for sharing their advice and their experiences. Thanking our sponsors too, Birdsong and AMC Health. You can visit them at amchealth.com and birdsonglife.com. And of course, we want to thank you, our listeners. Once again, this is Kim Marcellus for McKnight's. Have a great day and come back again soon.